Welcome to Epilepsy Management and Beyond. My name is Donna Avanecean, and I will be your presenter today. Welcome. So if you have not already viewed my previous presentation, circuit breakers and epilepsy, please do so as I go into more depth about the diagnosis of epilepsy. Today's presentation will be focusing on surgical management of persons with epilepsy. So to begin, I'd like to share a little information about myself. I have over 30 years of neuroscience experience. I have various subspecialties, including neuro-oncology, neurovascular, epilepsy, and movement disorders. When I'm not functioning as an APRN provider at the Epilepsy Center for Ayers Neuroscience Institute, my other hat or role is the current director for the Hartford Healthcare Medical Group Advanced Practice Providers Specialty Division. I provided you with my email address, and please feel free to contact me directly if you have any questions or recommendations. Okay, so for the objectives for today's presentation, we will specifically address the criteria for considering individuals for surgery. Start off with discussion around the purpose of epilepsy surgery. So understanding that epilepsy has a major impact on individuals' quality of life. Many of them cannot hold down jobs because of the number and amount of seizures that they're experiencing, or the side effects that they're experiencing from being on multiple medications. Many of them, because of either their EEGs or frequency of seizures, are unable to drive. This has a lot of impact on their quality of life. So when you have reached a point where a patient may be on 2, 3, 4 anti-seizure medications and are still having frequent seizure breakthrough, you want to start to think whether or not your patient would be an excellent candidate to have epilepsy surgery, with understanding that you're either going to eliminate the seizures or at least greatly reduce the seizure burden in the individual with drug-resistant epilepsy. Now, drug-resistant epilepsy, by definition, is when you have failed 2 or more anti-seizure medications. And one of the things that I also failed to mention when we were talking about some principles of medication prescribing with individuals with epilepsy is that our goal is always one agent, because that's where you're going to achieve the maximum reduction of seizure burden. By adding a second agent, you may reduce your seizure burden by 85%, although there's a lot of epileptologists that would say it's even lower than that. And by adding the third or fourth agent, you probably are only going to appreciate anywhere from an 8 to 15% seizure reduction. So adding more medications is not necessarily going to yield a good goal or objective. So, the purpose of epilepsy surgery is to improve quality of life and to either eliminate or greatly reduce the seizure burden in individuals with drug-resistant epilepsy. Now, if you were to look at 2 major types of surgery that we talk about in epilepsy, the first is resective surgery, and we'll discuss all the different types of resective surgery that are available to our adult patients as well as children with epilepsy. And the second category, if you will, is neuromodulation. And by talking about who is a candidate, what do we need to do to see who is a candidate? So as I said, any individual who has failed 2 anti-seizure medication, in the back of our minds, the first thing that we're thinking as treating providers is there's a high likelihood, I know there's a high likelihood that this patient is probably going to fail other trials of medications. And what type of seizure surgery could I offer this person? Well, in order to make that decision, you need to do the surgical workup. And so the goal of the surgical workup is to primarily determine, if possible, because this is not always true that we can, determine the focality of locus for the seizures. Where is the epilepsy? Where are these seizures first starting? We have a lot of tools in our arsenal to try to help us make that determination. The easiest and the lowest hanging fruit is to get the person admitted to an epilepsy monitoring unit where they undergo video EEG monitoring. They are admitted, depending upon your center, they could be admitted for as little as 3 days to, as I've seen, as long as 2 to 3 weeks, in the hope of capturing the seizure events, looking at it from a clinical perspective, meaning what clinical characteristics do we see during the seizure? That's the video portion of it. And where is the corresponding EEG? What is that showing? Where is it starting from? So that can be the first thing that you do when planning for surgical workup. Now, let me just tell you that EMU evaluation is not only used in a surgical workup, it can be used in helping us and assisting us in making a diagnosis. Other parts of the surgical workup, we know the impact that epilepsy has, especially if epilepsy is being affected in very specific areas of the brain or is originating from certain areas of the brain, such as the amygdala, the hippocampus. We know that that is going to have a direct impact on memory and cognitive difficulties. So by completing neuropsychological testing with a neuropsychologist, we're able to determine that will help also in looking at where those deficits are from a cognitive standpoint, and again, matching it up to what we're seeing on the EEG. I would say that the majority of individuals with severe epilepsy will have a tremendous impact on their cognitive abilities. We also have them undergo an assessment of a social worker with a social worker to determine their support system, looking at if there's any other social stressors, such as determinants of health, that would impact their ability to have to go through the workup, and of course to eventually have the surgery. If somebody is suffering from food insecurities or housing insecurities, getting them through a surgical workup may be very, very difficult. We weigh very heavily or depend on heavily radiological imaging. All individuals, regardless of whether or not they're going to be considered for surgery later on, must undergo a 3 Tesla MRI of the brain, primarily with what we call an epilepsy protocol. We are specifically looking for 3 types of commonly seen anomalies, developmental anomalies that occur during brain embryonic development: specific cortical heterotopia, which is a migration of gray matter into the white matter. The second is mesial temporal sclerosis, which is a sclerosing of the temporal lobes that can lead to a decrease in the size of the temporal poles. And it is very evident on MRIs. And then finally, cortical dysplasia, which is another congenital anomaly where as the brain tissue and layers of the brain tissues are forming, there's a failure of segmental tissue that forms in a normal manner, and this can lead to causing a focus of seizures. PET scan, positron emission tomography, it will demonstrate decreased metabolism, which can indicate the site of seizure focus. Now, SPECT scan utilizes a tracer, a nucleotide tracer, which is injected into the patient at the time of seizure onset, which is predetermined. Sometimes an individual's clinical manifestations of the seizure will begin before the EEG will be noting to change, versus there are times when the EEG changes before we start to see the clinical characteristics or the semiology of the seizure. Approximately 4 or 5 hours after the patient has had their seizure and they have received the tracer, they are brought down to the nuclear medicine department. They undergo the scanning, the spectroscopy scanning. And now, which is different than the PET scan, you're going to see an area of hypermetabolism, which can indicate the location of the seizure focus. Now, we usually do the SPECT scans ictally, meaning at the time of the seizure, and then we wait the following day if they've not had any seizures. We also repeat the scan, and that's referred to as an interictal spectroscopy. Another imaging that we use is fMRI, which is a very specific MRI that improves location of language, motor, and if ordered with visual tractography, can also demonstrate from a functional standpoint where the visual pathways are. This helps the neurosurgeon in planning surgery to identify where the visual tracks are. So if someone is operated on, that they're not left with a visual field deficit. And WADA, not always performed on all of our pre-surgical patients. It's primarily for identifying language centers, and it does require a cerebral angiogram. The patient is brought in, it's a same-day procedure. And literally, they receive, through the cerebral angiogram, they receive an anesthetic agent, which will put one side of the brain to sleep and allows for the other to function. There is a neuropsychologist that is available during the testing, where both verbal and expressive, both expressive and receptive speech is tested. They're asked to identify objects, perform different tasks. And then once that's completed, then the other side is tested in the same fashion. But again, we do not employ this as much as we used to. Other testing that can be performed or can be ordered is something called a magnetoencephalography, also known as MEG. This is a non-invasive brain imaging technique. MEG works by using a superconducting quantum interference device known as SQUID and a computer. It measures neuromagnetic activity within the brain. MEG can detect, record, and analyze magnetic fields produced by the electrical activity in the brain. And by examination of the distribution of the magnetic fields, they're able to take that and superimpose it on an anatomical image of the brain. It aids in mapping brain function and to identify exact source of epileptic seizures. And usually it can be performed with an EEG running as well. Here is what the MEG looks like. Not all centers have them. In fact, even though we have a busy surgical program, we do not have one. The closest facility that does is in Boston, where we send our patients. Now, intracranial monitoring is required in most patients for epilepsy surgery. And remember now, we're taking all of that information that we got from our MRIs, from our fMRIs, possibly our WADA, possibly our MEG, the admissions to the epilepsy monitoring unit, and we're gathering all of this information. And then we get to a point after various discussions as a committee, and we decide, okay, we need to really try to now make a decision about whether or not this patient is, one, a surgical candidate, and two, what type of surgery are we going to recommend? So this is where intracranial monitoring has its place. It requires a minimum of a 2-week admission. In some organizations, it may be longer. It is usually the last step prior to final determination of which type of epilepsy surgery the patient is a candidate for, which I've mentioned. And there's essentially, we have 2 types. We can either place a subdural grid onto the brain surface. So a craniotomy is performed, the dura is resected back, and the grid is placed on a predetermined area of the brain. And you can put multiple subdural grids in at one sitting. The second type is known as a stereo EEG, and this requires placement of depth electrodes to previously determined areas. This is done under general anesthesia, and it is done stereotactically. It does not require a craniotomy. Rather, they make various burr holes. There are plugs that are put in, and then the electrodes are strategically placed. And again, this is where the discussion in a multidisciplinary conference comes in, where people are hypothesizing based on all of the data that we have, where they believe the seizure activity is coming from, where does it radiate to, in order to get the information that we need. Also, I want to mention that patients can have both. They can have both depth electrodes and subdural grids placed to maximize localization. Once the patient either has the grid placed or the electrodes or both placed, we then start to taper off the anti-seizure medication, because the goal of this is to try to capture and further localize where seizure activity is coming from. During the time that the patient is admitted, at some point, the neurologist, the epileptologist, will actually go up and perform cortical mapping. What they will do, and what they're going to do is, if in the case of a subdural grid, which now each one of these, so this is a multi-surface one, each one of these blue dots, if you will, is corresponding to receiving information from a particular part of the brain within the cortex and even the deeper structures of the cortex. So they will stimulate each of the electrodes to either reproduce the seizure or in order to see where the seizure activity is specifically coming from. So let's say they were to start stimulating these 3, and if it's over the subdural space, and it's on the subdural, and these 3 electrodes are receiving information from the temporal lobe, then once they stimulate that area, they're going to see changes on the EEG corresponding to those specific electrodes. So this is very, very helpful in trying to localize electrodes, a little bit different. So here are the plugs. Here's the stereotactic frame that is put on. The plugs are inserted, and then through stereotaxis, the electrodes are placed into the predetermined areas of the brain. This is primarily used when we're trying to get information in the deeper recesses of both the white and the gray matter. This is what the electrodes look like. And this allows us to better identify where the seizure focus is coming from. Now, surgical decision-making, I already started to talk to you about, I said there's a committee. Well, there is a committee that comes together depending upon your organization. Our group meets weekly, and it's a multidisciplinary case conference. We have neuropsychologists, neuroradiologists, we have our neurosurgeons who primarily perform epilepsy surgery, our social worker, obviously the epileptologist is the person who is presenting the case, and we all get together and we discuss and review every single source of information. There is usually a hypothesis. I've mentioned this before. There's a hypothesis about, based on the patient's seizure presentation, their semiology, where we hypothesize the focus of the seizure activity is coming from. That's the hypothesis that is developed. The overall time that it takes from the time that we make a decision that a patient is a surgical candidate to the time that they actually at least have the epilepsy surgery, if not the intraoperative, the electrode, the depth electrode, or the subdural grid recordings, is about 6 months. So there's a lot of back and forth. There's a lot of delay. Some of this is patient related. Halfway through the workup, they'll get very nervous and they'll say, "I don't want to do this anymore," which is fine by us. And then later on, a couple of years later, they're saying, "Okay, things have gotten better. I'm ready to proceed." And sometimes that means that we have to start the whole surgical workup over again. So in conclusion, I want you to come away with some takeaway points in regards to epilepsy surgery. Unfortunately, it is not useful. Not every patient is an epilepsy surgical candidate, unfortunately, and this is independent about whether or not they're intractable or refractory to standard medical management. It requires a very thorough evaluation, including assessment of patients' social support. And the overall benefits from epilepsy surgery include reduction in seizure frequency, improved quality of life, and reduced need for medications. I wish to thank you for your time and attention, and I hope that you have found this presentation very helpful. You have my email address, and I really do value any feedback that you can give regarding this presentation or any other future presentations you would like to hear. Thank you and have a great day.